Welcome to our presentation on urinary incontinence types and management. Today, we will explore the various forms of urinary incontinence and discuss effective management strategies. Let's begin our journey into understanding this common yet often overlooked condition. Our learning objectives are threefold: to understand the types of urinary incontinence, identify risk factors and diagnostic tools, and explore treatment modalities. By the end of this session, you will have a comprehensive understanding of these key areas. Let's examine bladder innervation. The parasympathetic system activates bladder contraction for voiding, while the sympathetic system aids urine storage. The somatic system provides voluntary control. Central control coordinates these functions, ensuring proper micturition. Urinary incontinence can be classified into several types: stress, urge, mixed, overflow, functional, and continuous incontinence. Each type has distinct characteristics and requires specific management approaches. Stress urinary incontinence involves involuntary urine leakage during activities that increase intra-abdominal pressure, such as coughing or sneezing. Risk factors include childbirth, pelvic surgery, menopause, obesity, and high-impact activities. The pathophysiology of stress incontinence involves impaired pressure transmission. Impaired pressure transmission is due to urethral hypermotility from weakened pelvic floor or intrinsic internal sphincter deficiency. Increased bladder pressure from activities that increase abdominal pressure can overcome the urethral resistance, causing urine leakage. Diagnosis of stress incontinence includes a history of leakage during exertion, physical exams, and post-void residual urine measurement. Urodynamic studies may be conducted if the diagnosis is unclear or for surgical planning. Management of stress incontinence often begins with conservative measures. Pelvic floor muscle training, lifestyle modifications, and bladder training are first-line treatments. These approaches aim to strengthen pelvic support and improve bladder control. Pharmacological management of stress incontinence includes topical vaginal estrogen and duloxetine. While no FDA-approved oral medications exist in the U.S., these treatments can enhance urethral function and provide symptom relief. Surgical management options for stress incontinence include mid-urethral sling procedures, urethral bulking agents, and Birch colposuspension. These interventions aim to provide structural support and improve continence. Urge incontinence is characterized by involuntary leakage accompanied by a sudden, strong urge to void. Causes include neurologic disorders, aging, bladder irritants, and urinary tract infections, leading to detrusor overactivity. Clinical features of urge incontinence include a sudden urge to urinate, frequent urination, and nocturia. Diagnosis involves clinical history, exclusion of UTIs, and urodynamic studies if needed to confirm the condition. Management of urge incontinence includes antimuscarinics such as oxybutynin to inhibit bladder contractions, beta-3 agonists such as mirabegron to relax the detrusor muscle, and lifestyle modifications. Watch out for side effects of antimuscarinics such as blurred vision and cognitive changes, especially in elderly patients. Advanced therapies like botulinum toxin injections and neuromodulation are considered for refractory cases. Mixed incontinence involves both stress and urge symptoms. Management focuses on treating the predominant symptom through behavioral therapy, pharmacologic treatment, and surgical options if necessary. Overflow incontinence results from chronic urinary retention, often due to bladder outlet obstruction, such as in prostate enlargement or detrusor underactivity. The bladder becomes overdistended, leading to small amounts of leakage. Clinical features of overflow incontinence include frequent dribbling and weak stream. Diagnosis involves post-void residual, PVR measurement, using bladder scan or urinary catheterization, which shows a high PVR. Urodynamic studies may be needed to assess underlying causes. Management of overflow incontinence includes behavioral measures like timed voiding and bladder decompression through catheterization. Monitoring fluid intake and managing constipation are also crucial. Pharmacological management of overflow incontinence includes alpha blockers such as tamsulosin to relax the bladder neck and 5-alpha reductase inhibitors such as finasteride to shrink the prostate. Surgical intervention may be necessary for structural obstructions, with bladder augmentation considered in severe cases. Functional incontinence arises from physical or cognitive impairments. Management focuses on improving mobility, scheduled toileting, environmental modifications, and caregiver support to prevent accidents. Continuous incontinence involves persistent leakage due to anatomical defects like fistulas. Diagnosis is confirmed through exams and imaging, with treatment primarily surgical to correct the underlying issues.